Hello, everybody. I'm Dr. Meenakshi, one of the doctors at Study Medic and mentor for Study EFOG. So today we are dealing with antenatal care, where we'll be doing set of questions on both EMQs as well as also we've got SBAs. So let's start off with the EMQs first, and then we'll go towards the SBAs. So antenatal care today we'll be dealing with three important topics. One is hypertension and pregnancy, and then we have got questions on fetal growth restriction. It's very, very important that you need to be updated with the latest guidelines, especially there is a chart wherein there is different kinds of fetal growth restriction, where when you would deliver which case, what could be the risk factors, and all these like the mode of delivery as well as the gestational age of delivery. All of this, it's very important that you all must be aware of, and we'll be discussing about that as well in today's class. And we've also got twins, where you need to be updated with both the monochorionic as well as the dichorionic kind of twins, as well as we'll be dealing with certain questions related to twin total transfusion syndrome as well as selective growth restricted fetuses. So without further ado, let's first see the EMQs which are related to hypertension. So in each of these topics, since we've got three topics, in each topics you'll be given 5 EMQs as well as 5 SBAs. So that amounts to 15 questions each from each of these topics. So when you get these options, so firstly you have you understand that it is related to hypertension, which is based on the options that is being given. So we've got chronic hypertension, gestational hypertension, white coat hypertension, superimposed preeclampsia with severe features, HELP syndrome, starting of low-dose aspirants, starting oral labetalol, oral nifedipine, administering IV labetalol and magnesium sulfate, immediate delivery after maternal stabilization, expected management with close surveillance, administer corticosteroids and continue the pregnancy, and discharge with home BP monitoring. So either that can be related to the definition of hypertension or it's related to the management of hypertension. Please read the question carefully, whether they're asking about immediate management, whether they're asking about the most appropriate or the definitive management. Read the question carefully and then we'll be answering. So the first question based on this EMQ is, we've got Dr. Elena who reviews Mrs. Leela Ahmed, a 31-year-old second gravida at 9 weeks and 5 days. So at booking, her blood pressure is 154/96 millimeters of mercury, and repeated at 150/94 after 20 minutes of rest using appropriate cuff size. She is asymptomatic. Her urine dipstick shows no proteinuria. Baseline investigations shows a hemoglobin of 11.8, platelets of 2.75 lakhs. Creatinine is within normal limits. ALT and AST are also within normal limits. She reports being diagnosed with hypertension 3 years earlier and intermittently taking amlodipine, but stopped once the pregnancy was confirmed. BMI is 33, previous pregnancies uncomplicated, there's no history of renal disease or diabetes, fundoscopy is normal. She asks whether this is pregnancy-induced hypertension and whether the diagnosis can affect the long-term surveillance and what is the most appropriate diagnosis. So as you can see over here, now that she's G2 and she's come for booking, even at the booking, her BP is 150/94. Which means that it's definitely not preeclampsia or gestational hypertension, because for that you need to have the onset after 20 weeks. So why is she having blood pressure in the first trimester? And then you look at the investigations, everything seems normal. And then she gives the history that she's got hypertension since 3 years, which itself means that she is chronic hypertension and this is not gestational hypertension. The second question is Mrs. Sophia Marino, 27-year-old, who's primary at 28 weeks of gestation, presenting for routine review. Her BP over 2 visits within 24 hours ranges between 148 to 156 systolic, and diastolic is 92 to 98. She denies any headache, visual disturbance, or epigastric pain or reduced fecal movements. Urine protein creatinine ratio is 0.4. Platelets are 2.38 lakhs, and AST is 23. Creatinine is 0.74. And fetal biometric corresponding to 45th centile. Amniotic fluid normal. Umbilical artery Dopplers are also normal, and she is admitted for observation. BP is persistently above 150/95 millimeters of mercury, and she's not currently on any kind of antihypertensives, and there are no other severe features. She is concerned about the risk of stroke and fetal growth restriction. What is the most appropriate next step in the management? So as you can see in this, that she is at 28 weeks. That's important. She is a primary, and then you see that her blood pressure is definitely in the higher range, and she's not got any kind of imminent symptoms. Right, rest of the investigations, everything appears to be normal, and she's admitted, which means that she's not started on any antihypertensives based on the instructions. So the first choice is obviously to go for oral antihypertensives, and we'll be starting with oral labetalol. Coming to the third question, which is Mrs. Aisha, 32 weeks, who presents to the triage with persistent frontal headache and photophobia. She's got no previous hypertension. On examination, blood pressure is 170 by 112 millimeters mercury, repeated at 168 by 108 after 15 minutes. Reflexes are brisk. There is no clonus. Protein creatinine ratio is 0.38. Platelets are 1.5 lakhs. AST is 36 and creatinine is 0.9. CTG is reactive and the USG shows the fetal growth is at 25th centile. Oral 200 mg of labetalol is administered, but systolic BP still remains above 165 millimeters of mercury after 45 minutes. She remains neurologically intact. And what is the most appropriate immediate intervention? First is the stabilization of BP. So you start off by giving the IV labetalol, which is very, very important in this. Firstly, stabilize the BP, and then you can look for her symptoms, whether they are responding. And then based on that, you can again further go for, the further treatment, which, if it is still persistent and if it is not responding, then maybe you can go for further treatment and she might be requiring delivery as well. Mrs. Martha Silva, who's 35 weeks of gestation, presenting with severe epigastric pain and visual scotomata. BP is 172 by 114 and protein creatinine ratio is 0.6. Platelets are 1.18 lakhs and ALT and AST are also rising. And creatinine is 1.05. CTG is reassuring. She receives IV antihypertensives and the PP is reduced to 148 by 92. She is hemodynamically stable. Ultrasound shows an estimated fetal weight at 18th centile with normal Likert and Doppler. There is no evidence of any abruption. She asks whether the pregnancy can be continued until 37 weeks for fetal maturity. What is the most appropriate definitive management? As you can see in this, that they are asking about definitive management. So you know that she's got severe epigastric pain with visual scotomata, which are imminent signs. And then they are telling that the BP is high, but of course the antihypertensives are given. And you've also seen that there are altered LFTs and platelets. Probably this can be HELP syndrome. So therefore, you need to go for an immediate delivery. If they're asking most appropriate definitive management, if they're asking next step, you can add about magnesium sulfate. But here you go for immediate delivery because the antihypertensives are already given. So the next step would obviously go for magnesium sulfate and then followed by delivery. But the definitive management is definitely going to be delivery. The fifth and the last question for this set of EMQ is Mrs. Nadia Ibrahim, 36 weeks and 6 days. She collapses at home with a witnessed tonic-clonic seizure lasting approximately for 90 seconds. On arrival to emergency department, she is post-ictal, maintaining airway with BP of 178 by 118. Saturation is 97% at room air. Urine dipstick shows 2+ proteinuria. So we have got two different findings here. That two findings which you need to note is high blood pressure as well as urine dipstick. Platelets are above 2 lakhs. ALT, AST is within normal limits. Creatinine is also normal. CTG is reactive. There's no history of epilepsy. She regains consciousness, but she appears confused. IV access is also secured. Bloods are sent. Obstetric team is preparing for immediate urgent management. What is the most appropriate immediate pharmacological management? In this case, obviously, you will be giving magnesium sulfate because as you can see over here, that her blood pressure is high and also she's already got epilepsy, which means it's pointing towards eclampsia. And the dipstick is also showing 2+ protein. So definitely they've secured an IV access. And it's important that naturally you will be delivering her. But prior to that, they're asking you about pharmacological management. So therefore, you have to go for magnesium sulfate here. And coming to this, the certain important concepts which you need to be understanding is hypertension, which is less than 20 weeks, where it's called as chronic. Treat persistent blood pressure when it is more than 140 by 90. Severe blood pressure of more than 160 by 110, you have to go for IV therapy urgently. And severe preeclampsia more than 34 weeks, you need to deliver. And magnesium sulfate reduces the eclampsia risk by about 50%. So the second set of EMQs is on the twin pregnancy, where we've got certain options like immediate delivery by emergency cesarean section, administering antenatal steroids and then planned delivery within 48 hours, continuing 2 weekly ultrasound surveillance, weekly ultrasound with umbilical artery as well as ductus venosus Doppler, fetoscopic laser ablation of placental anastomosis, amnio reduction, starting aspirin 150 milligrams until 36 weeks, elective delivery at 36 weeks, elective delivery at 37 weeks, elective delivery at 38 weeks, selective fetal reduction, administering magnesium sulfate for neuroprotection, admit for inpatient monitoring and daily CTG, and offer invasive testing with amniocentesis screening for gestational diabetes now. So the first question is that Mrs. Aisha, who's 27-year-old primigravida, had a spontaneous conception booked at 9 weeks. First trimester ultrasound shows that there is a single placenta with a thin intertwin membrane and absence of lambda sign, which is confirming that it's a monochorionic diamniotic twins. She has been undergoing 2 weekly surveillance from 16 weeks. At 21 weeks, she reports rapid abdominal distension and breathlessness. Blood pressure is 112/68, urine negative for protein. The ultrasound shows first twin with deepest vertical pocket of 10.2 centimeter and visible cardiomegaly. Twin 2 has got DVP of 1.1 centimeter with non-visible bladder over 40 minutes of observation. Estimated fetal weight is discordance is 28%, but Dopplers in both the cases are normal, and the cervical length measures 30 mm. Maternal HB is 11.2. There is no structural anomalies. Glucose tolerance is normal. What is the most appropriate management? As you can see in this condition, that she has got an MCDA twins, and the picture is suggestive of a twin-to-twin transfusion syndrome. She's also showing breathlessness, and she's having abdominal distension, which is rapidly increasing. So based on the options which are available, definitely if you can look into this, yes, you will have to be doing ultrasound surveillance, but prior to that, the most appropriate one is that you'll have to be doing the laser ablation, that is to treat the TTTS. That's when she will be relieved, and that is going to be helping her in this condition. Then we've got Mrs. Sarah Thomas, who's 35-year-old, second gravida, conceived with IVF at 12 weeks of gestation. USG confirms DCDA twins, and there's a lambda sign with 2 distinct placentas. Crown rump lengths are concordant. Her BMI is 32. Blood pressure is 124/78. Baseline investigations are HB is 12.1, platelets are 2.5 lakhs, and fasting glucose is 4.8 millimoles per liter. Urine protein is negative. She has no chronic hypertension or diabetes, but has gestational hypertension in previous singleton pregnancy at 37 weeks. She asks about preventive strategies to reduce the complications specific to twin pregnancy. And uterine artery Dopplers at 12 weeks shows that there is an elevated mean pulsatility index above 95th centile. She is otherwise asymptomatic and is keen for evidence-based recommendations to optimize the pregnancy outcome. What is the most appropriate additional intervention at this age? So now you know that she is at 12 weeks with DCDA twins. Her BMI is high, blood pressure and everything appears to be normal. Previously, she had gestational hypertension, not now. And later, now she's only in this pregnancy, as you can see, so far the significant finding is that she's got DCDA twins, umbilical artery showing elevated PI. So therefore, she's asking for preventive strategies. And when you look at this, you know, obviously from the options, which is very clear that you won't go for delivery, and no steroids and all are definitely not required right now. 2 weekly ultrasounds not required currently for DCDA twins. Weekly ultrasound with umbilical artery Doppler is not required. We don't go for laser ablation here. Amnio reduction is not there. She's asking for preventive strategies. So therefore, aspirin 150 milligram night would be sufficient. We anyways will not go for deliveries, and obviously magnesium sulfate and all, she does not have any kind of symptoms, or probably you don't need to deliver her, so therefore that option is not fitting in. There's no need to do any kind of invasive testing, and also for GDM screening. So currently, because it's already her sugars have already been checked. So in this case, you only need to do the preventive strategy, which is about giving the aspirin. And then we've got Mrs. Linda Smith, who's 29-year-old primigravida with monochorionic diamniotic twins, who attends at 27 weeks of gestation for routine growths. So just remember, she's at 27 weeks. She's had 2 weekly scans. You know that 2 weekly scans would be done in case of monochorionic pregnancies. So blood pressure is normal. Urine is negative for protein. Ultrasound shows the first twin is weighing about 1.1 kgs, which is at 45th centile. And the second twin is at 730 grams, which is less than 3rd centile. That is about 34% of discordance. Fluids are normal in both the sexes. Umbilical artery Doppler in twin B is showing an intermittent absent end-diastolic flow, but the ductus venosus is normal. Middle cerebral artery is also within the normal range. CTG for both fetuses are reactive, and HB is 10.9. Platelets are normal. She is asymptomatic, anxious regarding the risk of IUD of the smaller twin and neurological injury. What is the most appropriate management? So once you get to know that, here you can see that there is a discordance, which means that there's going to be growth restriction. Plus, at the same time, the twin B is also showing that there are some Doppler changes. And when you know that there are these Doppler changes, what you will be doing is the frequency of the scans would be increased. So you will be going to weekly ultrasounds. Initially, we were doing 2 weekly, but since now the Dopplers are coming to be abnormal, so based on the options which are available, that's the only option. Sometimes you also would be getting different options, so make sure that you don't get confused on this. Now you need to monitor more frequently because she's only at 28 weeks currently, 27 weeks and 5 days. So now 2 weekly scans might not be sufficient, so just go ahead and do weekly ultrasound and monitor for the ductus venosus. Then we've got Mrs. Nadia Patel, who's 30-year-old, third gravida, presenting with dichorionic diamniotic twins. This is DCDA twins at 32 weeks with painful contractions for 6 hours. She has got more rupture of membranes, and on examination, cervix is 3 to 4 centimeters with 70% effaced. Membranes intact, CTG showing reassuring traces, moderate variability, and no decelerations. Estimated fetal weights from the scans show about 1.9 and 1.8 kgs. That is at 32 weeks. Blood pressure is normal, temperature normal, CRP is 5, urine analysis is negative, and there are no features of chorioamnionitis. Neonatal team has already been informed, and she asks about interventions to improve the neonatal outcomes should delivery occur soon. So obviously this does not require any kind of further explanation, so we can go for corticosteroids, right? That is very, very important in this particular case. You know, now that she is almost into established labor, she's at 4 centimeters dilated. So improve the neonatal outcomes, you may go for the antenatal corticosteroids because she is just at 32 weeks. So wait for the steroid coverage, and meanwhile if she's progressing then it's okay, but at least you should have been covering the doses of steroids for the baby, so that there will be improved neonatal outcomes. Next, Mrs. Nera, 31-year-old, has an uncomplicated monochorionic diamniotic twin pregnancy with chorionicity determined at 11 weeks with absent lambda sign. She has undergone 2 weekly surveillance, and there is no evidence of TTTS or TAPS or selective fetal growth restriction. At 35 weeks, 6 days, ultrasound shows twin 1 is cephalic. Estimated weight, fetal weight is 2.6 kilos. Twin 2 is again cephalic with 2.5 kilos. Discordance is only 4%. Amniotic fluid is normal. Umbilical artery and MC Dopplers are normal. BP is 116/74. OGTT at 24 weeks was normal. CTG is also reactive for both the fetuses. She is asking about optimal time for birthing in order to balance the stillbirth risk against prematurity. What is the recommended timing of delivery? So the question here is very, very simple. They just want to know about the uncomplicated monochorionic diamniotic twin pregnancy delivery timing, which is obviously going to be from 36 weeks onwards. So obviously in the EFOG exams, the scenarios are going to be very, very long. But once you read it for the first time, in the first glance itself, you should be able to understand what exactly they are asking for. And thus, although the scenario appears very, very big, and it's quite a long scenario, but you know that they are technically asking only for the recommended time. But make sure that you get to know whether it's an uncomplicated, whether they've got any complications, you should be able to derive from that particular scenario. So MCT twins obviously will be doing 2 weekly surveillance. Whenever there is TTTS, which is going above, and if it's stage 2, then you go for laser therapy. Whenever there is absent end-diastolic flow, then obviously you'll do intense Doppler surveillance, which is what we were discussing about, where you increase the frequency of the Dopplers. And imminent preterm birth, when it is in less than 34 weeks, you go for corticosteroids. And delivery timing for MCT, if it's uncomplicated, it's 36 weeks. For DCDA twins, it's going to be after 37 weeks. So that completes the second EMQ, and now we are coming to the third EMQ, which is very, very important on fetal growth restriction, where we have got these set of options where they're saying whether it's constitutionally small for gestation age. Probably they're giving you some scenarios and asking you to find out what is the diagnosis. Early onset FGR with raised umbilical artery pulsatile index, early onset FGR with absent end-diastolic flow, early onset FGR with reversed end-diastolic flow, late onset FGR with abnormal CPR. So early onset is anything that comes in under 32 weeks, and above 32 weeks would be called as late onset. Abnormal ductus venosus A wave, maternal low dose aspirant prophylaxis, immediate delivery by emergency cesarean, expected management with intensive Doppler surveillance, delivery at 37 weeks, delivery at 34 weeks after corticosteroids, fetal anemia requiring MCM monitoring, and torch infection related FGR, placental insufficiency secondary to preeclampsia, genetic anomaly which is associated FGR, so you can go for invasive testing. Mrs. Anita Rao was 28, G2P1, presenting at 29 plus 5 weeks. So note the gestation age over here. Her previous pregnancy was uncomplicated. Okay. She is normotensive, 116/72, but there is no proteinuria. BMI is also normal. So far, the only feature that you have to register is that she's at 29 weeks, 5 days. Fundalitis 25 centimeters, lagging by 4 centimeters. Yes, the fundalitis small. Ultrasound was done, which showed the estimated fetal weight at 2nd centile with AC, abdominal circumference of less than 3rd centile. Amniotic fluid index is 10 centimeter. Umbilical artery Doppler shows pulsatility index of above 95th centile with preserved end diastolic flow. Middle cerebral artery is normal. CPR is also normal. Ductus venosus is also normal. And to see the growth over 2 weeks shows static abdominal circumference with declining growth velocity, and CTG is reactive. HB is 11.4, platelets are 2.3 lakhs, AST is normal, creatinine is normal, and there are no structural anomalies. What is the most appropriate classification? So in this, you know that whenever there is any kind that, the fetal weight is going less at about 2nd centile, right? And also you see the abdominal circumference is less than 3rd centile. Umbilical artery is showing the Doppler changes, which is pulsatility index above 95th centile. And since she's under 32 weeks, this comes under early onset FGR. Mrs. Shreya, 33, primary at 31 weeks, 6 days. Here, 31 weeks, 6 days, and she's a primary with worsening headache and epigastric discomfort. BP 152/98, urinalysis shows 2+ protein. Ultrasound shows EFW, estimated fetal weight at 3rd centile with AFI of 5 centimeters only. Umbilical artery Doppler shows absent end diastolic flow. MCA Doppler shows increased diastolic flow consistent with brain sparing physiology. And ductus venosus is normal. CTG shows normal baseline with variability without decelerations, and platelets and ALT, AST, as you can see, slightly above. Platelets are 1.3 lakhs and creatinine is 1.1. Uric acid is elevated. She has got antihypertensives as well as magnesium sulfate. What is the most appropriate management? Obviously, in this case, you have to go for an emergency cesarean section. You do an immediate delivery based on the options which are available. Okay, obviously, they're not asking for classification, so you rule out all of these options, right? Now you will be confused whether you want to go for expected management, whether you would like to deliver at 34 weeks because the ductus venosus is normal. So you may get that benefit of doubt. But as you can look into this, you know that the mother is not stable. She's complaining of headache. She's having epigastric discomfort. Antihypertensives, everything is already been given. Magnesium sulfate is also given. And you can see that there are altered labs. So therefore, you will go for an immediate cesarean section. If in this case, only if there is fetal growth restriction and the ductus venosus is normal, then you wait until the ductus venosus turns abnormal, and that's when you deliver the woman. But in this case, because the mother is not stable, it's important that we'll have to be expediting the delivery. Mrs. Maria Fernandez, 35, G3 with chronic hypertension, and now she's at 30 weeks with reduced fetal movements. BP is very high, 168/104, despite giving labetalol. Ultrasound shows estimated fetal weight with severe oligohydramnias 1 percentile, and AFI is 3 centimeters. And umbilical artery is already shown reversed end diastolic flow. And MCA Doppler is abnormal. Ductus venosus shows a reversed A wave. CTG shows minimal variability with recurrent late decelerations. Platelets are also less. ALT is elevated. LDH is elevated. She's symptomatic with visual disturbances. And what is the most appropriate next step? And there is no two ways about it. Definitely, you will have to be going for delivering her because you know that there is abnormal Dopplers, the blood pressure is also very, very high, and antihypertensives are given. Platelets are also falling, which is indicative of help. And there is FGR. So therefore, you need to go for a delivery. Mrs. Sarah Ibrahim, 27-year-old, who has attended 36 weeks, 5 days, reporting reduced fetal movements over 48 hours. Blood pressure is 118/76 with fundal of 33 centimeters, and ultrasound shows estimated fetal weight is at 8th centile. A5 is 8 centimeters, umbilical artery Doppler is normal, MCA Doppler shows reduced pulsatility index, and CPR is below the 5th centile. Ductus venosus is normal, CTG is reactive, and serial growth scan shows that the abdominal circumference centiles are declining over the past 3 weeks, and there is no maternal disease identified. What is the most appropriate management? If you can look into this particular scenario, now she is at 36 weeks, 5 days. All you can know is that the CPR is less than 5th centile, and that's definitely a fetal growth restricted baby. But her blood pressure or observation, CTG, everything is normal. But it's a fetal growth restricted baby with CPR being less than 7th centile, less than 5th centile. So therefore, based on the options which are given to you, you will have to be delivering at 37 weeks. So they're not asking for classifications. So obviously, this is going to go there. Immediate delivery by emergency cesarean is not required here. Expected with intensive Doppler surveillance. Yes, you may give a doubt, but they are asking you about the next management. What are you going to do? And she's already at 36 weeks, 5 days, and the CPR is already altered. So the rest of the options are also not quite fitting in, and you have to you will have to be delivering the woman. And why is this? That's because you see that there is a fetal growth restriction and there is a cerebral redistribution, if you can see in this. So therefore, you will be requiring, because the CPR is less than 5th centile, you will be waiting and then you will be delivering after 37 weeks. Mrs. Kavita Menon, 30-year-old, presenting at 12 weeks for booking. Previous pregnancy was complicated by early onset FGR, requiring delivery at 30 weeks due to abnormal Dopplers. And placental histology showed maternal vascular malperfusion. In this pregnancy, her normotensive with BMI of 21. At 20 weeks, uterine artery Doppler demonstrates bilateral early diastolic notching and mean pulsatility index above 95th centile. Combined screening shows low PAPPA and HB is 12.1. Platelets are 2.4 lakhs, no thrombophilia, and she seeks advice regarding prevention of recurrence of placental insufficiency. What is the single most intervention? Obviously, she's got previous history of hypertension. Now, the uterine artery Dopplers were already done at 20 weeks, and that's also showing diastolic notching. And she's also having a risk factor where there is the pregnancy associated plasma protein is also found to be low. So therefore, she's at risk and you will have to be going for aspirin. And it's important that you will have to be starting the aspirin since she's already at 12 weeks of gestation. So please make sure that you have to be looking into the gestational age as well. And you'll be starting the aspirin only after 12 weeks, ideally before 16 weeks. So make sure that you look into options carefully to see which gestational age she is falling into. So the concepts here would be that if it's an early onset FGR, you have to go for Doppler driven management. That is, you keep monitoring ductus venosus and all of that. And based on that only you would be delivering unless the mother situation is compromised. Absent end diastolic flow, obviously you'll be delivering at 34 weeks if she's stable. And reduced end diastolic flow or abnormal ductus venosus would call for an urgent delivery. Late onset FGR with abnormal CPR, then deliver at 37 weeks. Aspirin reduces the the placental insufficiency recurrence. So this is what we were discussing about. This chart is extremely important for you all. So make sure that you go through this chart really well before you can, you go and attempt your exam. So obviously, you know that whenever the absent end diastolic flow is there, you have to deliver by 34 weeks. And then definitely if there is any other coexisting risk factors, you can consider from 32 weeks itself. Okay, carrying up to term becomes difficult. And then this was the question that we were dealing about, where the CPR is less than 5th centile. There is no need to go for any delivery before 37 weeks. Okay, you only need to go ensure that you do frequent Dopplers, and based on that, again, you will have to be discussing about the delivery plan. Provided the remaining condition, everything is stable. Here, the CPR being less than 5th centile, you can go for delivery from 37 weeks onwards. So let's look into some of the single-based answers and single best answers. Till now, we have completed the EMQs. I hope those EMQs were clear to all of y'all. Coming to the SBAs, the 42-year-old woman, multigravida, who has come at 11 weeks for regular ANC, and she's conceived naturally, well supported by her partner. Previous pregnancy was a low-risk one and had delivered by spontaneous vaginal delivery 2 years ago. Her BMI is 35 with no prior history of hypertension or diabetes. Her current BP is 120/80. PA is soft per abdomen, not palpable uterus. What is the best advice to reduce the risk of preeclampsia? So as you can see in this, that she is above the age of 40, right? That is one risk factor which you can look into. Secondly, she's also got a BMI of 35. And previously she had a low risk pregnancy, but currently she wants to know certain kind of advice regarding the reducing the hypertension. Yes, start aspirin 150 milligrams, but from when you've got still more better options, so you can choose them. From 16 weeks, not recommended. From 12 weeks, yes. Weight reduction, we don't recommend once she's pregnant, and aspirin is contraindicated due to BMI. That's not right. So you know this, that whenever they've got high risk factors, even one, like when they've got previous hypertension, or if they're case of chronic kidney disease, autoimmune diseases like SLE or APLAS, type 1 or 2 diabetes and chronic hypertension, you need to start the aspirin from 12 weeks onwards. And if they've got moderate risk factors, you have to look for more than one risk factor, like age, which is 40 and above, nulliparity, BMI, which is 35 and above, and you've got pregnancy interval of more than 10 years, if there is any family history of preeclampsia, and if there's a multifetal pregnancy. So in this list, if you've got 2 factors at least, then obviously she would be a candidate for starting the aspirin. A 32-year-old primary presents at 30 weeks for her regular visit, diagnosed with gestational hypertension when she was 25 weeks and was started on labetalol 100 mg BD. She has no complaints of headache or visual blurring and is able to feel her baby's movements well. Her pulse rate is 78, blood pressure is 135 by 80 millimeters mercury. Fetal heart rate is 144 beats per minute, and clinically, the symphysiospondilitis corresponding to gestational age, and she has got no proteinuria. How frequently should her BP be checked? So now, based on her symptoms, you understand that it's a clear-cut case of gestational hypertension and there are no other complications. And the BP is also well under control with oral labetalol 100 mg BB. So what you need to do? Daily twice check at home, not required so frequently. Every 48 hours at least, no, it is not required. Once daily, not recommended. Once a month till 32 weeks, followed by every 2 weekly later, no, this is not recommended. And once or twice weekly, yes, definitely you'll have to be choosing this option. So if you look at this table, this is very, very important that in women with gestational hypertension, you don't offer routine admission. You give the treatment once it is above 140/90. This is what we were reading, that if it's persistently above 140/90, you have to start the oral antihypertensives. The blood pressure target should be 135/85 or less. And when do you measure the BP? Once or twice a week until the BP is 135/85 millimeters mercury or less. Until it comes under check, you go for once or twice a week. Urine dipstick once or twice a week because you need to see whether she's getting converted to preeclampsia. Blood test, full blood count, LFTs and RFTs at presentation, and then you do weekly tests for them because they are hypertensives, and offer the PLGF testing on one occasion if there is a suspicion of preeclampsia. So you need not admit. When would you admit? When it is above 160/110, and then obviously the target blood pressure is going to be 135/85. And whenever she's inpatient with you, make sure that you have to measure it at least every 15 to 30 minutes, and daily urine dipstick would be done. And then the frequency of the tests also is going to be similar, weekly only, and PLGF testing also will be done on one occasion if there is any suspicion of preeclampsia. So please remember that once or twice a week, it depends upon the blood pressure. If it still need to become under control, then you have to do twice weekly, but otherwise once a week until you get the target blood pressure of 135/85. Please remember that one question. And a 27-year-old primary with pre-eclampsia, currently on tablet labetalol 200 mg BD. So mind you that it's pre-eclampsia here, and she's on labetalol 200 mg BD. And on her routine visit, you see at 30 weeks of gestation, blood pressure is 140/90. She's got no other concerns like headache or epigastric pain or any pain abdomen, and is able to feel her baby's movements well. Last ultrasound was 1 week ago, where the growth of the fetus was found appropriate with normal amniotic fluid volume, normal Dopplers, and estimated fetal weight was 1.1 kilos. How frequent should you repeat her liver and renal function test? So if you can look at this, whether it's twice a week, once a month, once in every trimester, once a week, and every fortnightly. If you know that it's a gestational hypertension, as you have already seen, that the blood test would be measured initially, you would be doing a presentation, and then you would be doing every week. But now you know that this is a pre-eclampsia case. So therefore, you will have to be measuring the blood test at least twice a week. And how do you measure the blood pressures? At least every 48 hours, and more frequently if the woman is admitted to the hospital. That is every 15 to 30 minutes when she is admitted. Here you measure every 48 hours. So once or twice a week if it's gestational hypertension, and if it's a pre-eclampsia, you have to measure it every 48 hours. The test would be repeated at least twice a week. 36-year-old second gravida with 28 weeks, known case of hypertension since 5 years, and currently on 100 mg labetalol TID. She has come with complaints of swelling of feet with blood pressure of 150/100, urine protein creatinine ratio of 50, which is elevated. In the first pregnancy, she was low risk and delivered by an emergency cesarean section in view of non-progression of labor with fetal distress. What's the diagnosis now? As you can see in this particular case, you see that she is now at 28 weeks, and she is already a known case of hypertension since 5 years. So obviously you don't call her as preeclampsia, or you don't call her as gestational hypertension, because she's already a known case of hypertension. And she's not eclampsia because she does not have any kind of symptoms. And now you see that, there is additional proteinuria to the existing hypertension. So therefore, it's superimposed pre-eclampsia. A 38-year-old multiparous woman with a known case of preeclampsia delivered by spontaneous labor 37 weeks. During pregnancy, she was on labetalol 200 mg BD. And her notes reveal that she is intolerant to ACE inhibitors and had developed cough when given in the past. So she was on labetalol, and she already delivered by natural labor. Okay, now she's a postpartum woman. She's currently breastfeeding, and her blood pressure is 150/88 and pulse rate is 84. She's got no headache or visual problems. Her urine output is normal. What is the choice of antihypertensive? So obviously in postnatal, we go for enalapril, but here you know that she's intolerant to ACE inhibitors, so you cut this option. And then you go for labetalol 100 mg. Labetalol, yes, can be given postnatally, but it's primary medication of choice when she's pregnant, not in postpartum. Then you may go for nifedipine, which is actually the drug of choice. No need of any antihypertensives, no, because her blood pressure is 150/88. Methyl-dopa, obviously we don't give in the immediate postpartum because of the risk of postnatal depression. So nifedipine becomes a choice here. As you can see in this, in preeclampsia, if they've taken any antihypertensives, you make sure that after birth they get their BP checked at least 4 times a day and every 1 to 2 days for up to 2 weeks. And you need to ensure that if at all they were on any antihypertensives, that needs to be continued even in the postpartum period. And you have to reduce the treatment if the BP is falling to less than 140/90. And you have to reduce the treatment if at all the BP is falling less than 130/80. Enalapril is actually the first choice, but because of the genetics, we don't give them in African or Caribbean family. We prefer giving nifedipine or amlodipine. So whenever they've got hypertension, if the blood pressure is not controlled, you have to give a combination of medications like nifedipine and enalapril. If this combination is not tolerated or if it is ineffective, that's when you add atenolol or labetalol to the combination treatment, or maybe you can discuss about swapping the medicines. But it's actually enalapril. Followed by that, you have to go for nifedipine or amlodipine. But otherwise, only if this doesn't work, then you add labetalol or atenolol to this. The beta blockers comes next line. Okay. 21-year-old primary with 24 weeks of gestation coming for a routine scan with MCDA twin pregnancy confirmed in the first trimester. USG showed that the recipient twin, the deep vertical pocket is 9 centimeters and donor has got 1.5 with absent donor bladder, reversed end diastolic flow in donor umbilical artery. Middle cerebral artery and ductus venosus are normal, and there is no evidence of any hydrops or fetal device. What is the stage of TTTS? So this is a pretty straightforward question. You need to just check about the Dopplers, about the bladder presence, and then based on that, you're supposed to grade the stage, right? So when you know that there is a discordance in the amniotic fluids, less than 2 and more than 8 if it is less than 20 weeks, and above 20 weeks it is more than 10 centimeters, the LICA. And donor bladder would be visible in this. Coming to second stage, the donor bladder is not visible because of the severe oligohydramnias that happens. Coming to the third, here is when you get the critically abnormal Dopplers. So in our question, the Dopplers were abnormal, so therefore you go directly for this. And fourthly, whenever there is any kind of effusions like ascites, pericardial, pleural effusions, and all of these scalpedema, hydrops, and when one of them have died, then that comes under stage 5. So remembering the stages is very, very important. And this is a hot favorite area where you can expect questions from TTTS. 37-year-old primary conceived with IVF with DCTA type of twins and complicated so far at 34 weeks. So see that she's primary, IVF conception, DCTA twins, and 34 weeks. She's clinically stable with normal BP and reports normal movements. Growth scan showed USG Doppler first twin is 1.5 kgs with normal Dopplers and normal amniotic fluid. Second baby is 2 kgs with estimated fetal weight discordance of 25% with normal amniotic fluid, and there is no structural abnormalities detected, and middle cerebral arteries are also normal. What is the subsequent plan of action? If you need to understand when you look at the subsequent plan of action, the first thing is obviously they'll be asking for weekly Dopplers, and this is DCDA kind of twins, right? So whether you do weekly Dopplers, whether you do it once every fortnight or after 3 weeks, there is no need to repeat the Dopplers because she's at 34 weeks, and repeat scan in 3 days, right? So what as per the guideline says is that whenever you see that the estimated fetal weight discordance becomes 20% or more, and or the estimated fetal weight of these babies is less than 10th percentile, either of this, or if you've got both in the second and the third trimester, you have to do weekly monitoring and including the Doppler assessment of the umbilical artery flow. And the first step is obviously whenever you have got discordance of 25% or more, make sure that you have to refer it to a tertiary care. So obviously when they ask you about what is the next management and they'll be giving you options, make sure that you read all the 5 options. Sometimes referral to fetal medicine unit also would be one of the options, and you're supposed to choose that. So when you think that the discordance is significant, 25%, or if you see that one twin is less than 10 centile, make sure that you have to escalate it to your fetal medicine, and following that only you're supposed to do the Doppler frequency increased to weekly. A 34-year-old with MCDA type of twins, now at 27 weeks, and USG Doppler showing that the first twin is at 45th centile with normal Doppler and amniotic fluid. Second twin is less than 10th centile, and with umbilical artery showing absent diastolic flow with estimated fetal weight discordance of 28%. So she is at 27 weeks. abnormal Dopplers, there's an early onset here, and there is no evidence of any TTTS. There is no evidence of oligohydramnios, polyhydramnios sequence. So when you get such things, you need to understand whether it's TTTS or whether it's a growth restricted pattern that the baby is following, selective growth restriction. So they are clearly given that there is no evidence of any kind of TTTS or A5 abnormalities. Only they say that the discordance is 28%, and they have made a diagnosis of selective fetal growth restriction, and the maternal condition is stable. What is the most appropriate next step? Offer scan every 2 weeks with continued surveillance. Fetoscopic laser ablation, that's the treatment that you would be giving only for TTTS if it is diagnosed. Referral to tertiary fetal medicine unit for surveillance, immediate delivery by cesarean section, and no intervention now. So basically, the first thing is you can see when you look at this chart, this is one table which you all must be very, very clearly aware of. And selective fetal growth restriction means when the estimated fetal weight of one is less than third centile, or there are two of the following 3 parameters. That means a growth discordance of 25% difference between the fetuses, the smaller fetus having an estimated fetal weight or abdominal circumference for less than 10th centile, abnormal umbilical artery pulsatility index. Okay, when you get 2 out of these 3, right, that's why you call it as selective growth restriction. In this, we've got 3 types. The first type is obviously whenever they've got positive diastolic flow. The second type is absent or reverse diastolic flow. That's when the frequency of your scanning would be increased. And thirdly, obviously, there's going to be a cyclical pattern, right? So whenever you know that there is a fetal weight discordance of greater than 20%, you have to do weekly increased ultrasound. That is very, very important. And also, whenever you get the diagnosis that it's going to be SFGR, make sure that there should be a referral for assessment and management in the fetal medicine unit. A 28-year-old multigravida with monochorionic diamniotic twins attending at 26 weeks, 3 days gestation. She is already in the fetal medicine unit over here. Okay. USG showing estimated fetal weight of 35th centile, normal amniotic fluid and umbilical artery showing positive in diastolic flow. Twin B shows an estimated fetal weight of less than 10th centile. Inter-twin established estimated fetal weight discordance is 27%. Umbilical artery showing persistent positive end diastolic flow with normal amniotic fluid, and ductus venosus is normal. Mother is clinically stable and there is no proteinuria. Diagnosis of SFGR1 is made. What is the most appropriate ultrasound surveillance? So you know that when that's positive diastolic velocities, you come under 1. If it's absent or reverse, that comes under SFGR2. So whether you'll do weekly growth scans with Dopplers, weekly growth scans is not required. Okay, when you have to monitor the growth, at least they should be spaced at 15 days. So at least every 2 weekly fetal growth scans with the weekly Dopplers. Okay, please understand the difference here. The growth scan would be done every 2 weekly, but the Dopplers needs to be done weekly. The Doppler assessment would be done weekly. Repeat Doppler after 3 weeks? No. Daily CTG? Not required. Repeat scan in 3 days? No, that's not the recommendation. So once you know that it's a selectively growth restricted baby, make sure that the fetal growth should be done at least every 2 weeks and the Doppler assessment should be done weekly. This is very, very important. 30-year-old primary gravida with MCDA kind of twins has been referred to a fetal medicine unit. Now she's already at FMU at 22 weeks of gestation, showing rapidly increasing abdominal distension and discomfort, probably could be TTTS. USG twin A showing DVP of 10 centimeters with enlarged bladder and mild cardiomegaly. Twin B showing the deep vertical pocket of 1.5 centimeters. Bladder is not seen during 45 minutes scan and estimated fetal weight is 18%. Dopplers are both normal and there is no evidence of hydrons. When the Dopplers are normal, obviously it's not going to be anything beyond stage 3. So it has to be stage 2. A diagnosis of stage 2 has been made. What is the best management? Now that she is at 22 weeks and you've already diagnosed, so the better option is definitely going to be fetoscopic laser ablation of placental anastomosis. They don't go for amnio reduction, that is not recommended. You better go for fetoscopic laser ablation. So when they're presenting in under 26 weeks, it is better that you treat by a fetoscopic laser ablation. That is very, very important. And then there is, this is some kind of literature which is for the TTTS management, where you will be talking about how frequent you will have to be monitoring the scans once the TTTS has been diagnosed. So there is evidence that, once the scans has been done, once you do the TTTS, weekly ultrasound needs to be done and serial assessment should be performed. And once it is like first 2 weeks, you do it weekly. And then after 2 weeks, you have to increase the interval to every 2 weeks. Next. 28-year-old multigravida attends fetal medicine unit at 31 weeks of gestation for fetal surveillance. Her previous pregnancy was a low-risk spontaneous vaginal delivery at term. And when you did an examination, you found that the fundal height is lacking by 3 weeks. And she's currently asymptomatic with normal blood pressure, no proteinuria. Ultrasound shows that umbilical artery pulsatile index is more than 95th centile. End diastolic flow is also present. In middle cerebral artery is less than 5th centile. And CPR is 12th centile with ductus venosus normal. Her CTG is reassuring. What is this interpretation? They're just asking you to diagnose. So in this, you know that she's at 31 weeks currently. Okay. Deteriorating fetal growth restriction, immediate delivery, not required. Compensated fetal growth restriction, continued close surveillance. Yes, this is one of the possibilities. Shows established fetal hypoxia. No, when the CPR is completely compromised, that's when you call as fetal hypoxia, the brain sparing effect. Otherwise, here it doesn't look like so. Normal Doppler variant in less than 34 weeks. Obviously, this is not a normal Doppler variant. Switching to weekly MCA Doppler only. No, just doing MCA Dopplers is just not sufficient. Okay, they're asking you the interpretation, right? So you have to say that compensated fetal growth restriction, continued close surveillance. This is what you will have to be choosing based on the options that are given to you. So whenever you know that there is a raised pulsatility index, as you can see in this, that is showing that there is an increased placental resistance. And MCA is less than 5th centile, which shows a brain sparing effect. That means that there is going to be compensation. CPR is reduced, and DV, that is the ductus venosus, shows that there is no fetus decompensation. As you can see, in less than 32 weeks, we wait for the ductus venosus abnormalities. Mother is also stable. So unless the ductus venosus, you know, over here is that it is found to be normal. So therefore, you have to be waiting, and it is called as a compensated fetal growth restriction. A 32-year-old G2 with prior stillbirth, BMI is 30, now at 10 weeks of gestation, coming for booking visit. Her previous records showed that the BB is 1.9 kilos with less than 3rd centile, stillbirth at 35 weeks, and there was no anomaly scan in the baby. And placental histology revealed uteroplacental insufficiency. What is the most appropriate surveillance done in this case? So as you can see here, now she is G2 and she's got prior stillbirth. That is one risk factor. And previous records show that the baby was actually a fetal growth restricted baby, and stillbirth was at 35 weeks of gestation. So in this pregnancy, what are you going to do? 4 weekly scans from 20 weeks of gestation, serial SFH measurements, that is just not sufficient. Routine anomaly scan and repeat growth scans only if there is a clinical suspicion of small baby, no. Uterine artery Doppler would be done, yes. And if it is abnormal, followed by serial scans from 28 weeks onwards, or if it is abnormal, followed by serial scans from 32 weeks onwards. If at all it is abnormal, you need to go for more vigilant monitoring. Therefore, you do serial scans from 28 weeks onwards. As you can see in this chart, she has got a previous stillbirth and the baby was found to be 1.9 kilos, which is a previous small baby. So you would do prescription of aspirin if at all she had some hypertensive disorder, and then you would be doing the uterine artery Doppler. Okay, so here it is actually a 3rd centile baby, less than 3rd centile. It's a fetal growth restricted baby. So therefore, you have to consider giving aspirin in her case and do a uterine artery Doppler. If at all it is abnormal, then you have to do from 28 weeks onwards. Okay. 32-year-old primary with BMI of 18 and with the currently a smoker of 6 to 8 cigarettes in a day, booking at 10 weeks of gestation. She has no significant past medical comorbidities and a booking blood pressure is normal. There is no other significant family history. Here you can see that, you know, her BMI is low. That is only risk factor that you can notice over here. First trimester investigations are reassuring. You are planning her most appropriate antenatal surveillance strategy as you're considering her risk for fetal growth restriction. What is the most appropriate management? Whether you would be doing uterine artery Doppler to 20 to 24 weeks, as you can see in this chart, whenever her BMI is less, it comes under moderate risk factor. Okay, when it is less than 18.5, and if she's got any other eating disorders, etc. Right? In that cases, what you have to do is that you have to be checking whether she's got any other history of placental dysfunction and do an anomaly scan, and you can do a serial scans from 32 weeks onwards. That is based on that particular chart. Okay, so uterine artery Doppler is not required unless she's got any other problems. Like in this case, as you can see, that she is definitely having the moderate risk factor, right? So therefore, you have to be only doing this and taking the history of her smoking as well as taking her BMI. You have to be doing the serial ultrasounds from 32 weeks. You'll be doing a uterine artery Doppler only if she's got any medical comorbidities, any APLAs or SLEs, any hypertensive disorders, or in, you know, if she's got a previous fetal growth restricted baby or any hypertensive disorders, or if she was having a previous stillbirth. And previous stillbirth is again to, you know, when it is because of a small baby, then that would be coming under high risk factor. Okay. And if at all it was an average gestational age, then and it was a stillbirth, then it comes under moderate risk factor. But you know that based on the history, like which risk factor, whether it was a small baby or whether it was a normal size, based on that you're supposed to categorize the woman. So only when you think that she's got these risk factors, you go for uterine artery Doppler. Otherwise, serial assessment would be sufficient in her case. 32-year-old primary coming for routine trimester screening, and she's otherwise well with a BMI of 24, non-smoker, non-alcoholic, no medical comorbidities, and no family history of hypertension with normal blood pressure. Screening test normal, shows NT of 1.5 mm and low risk of aneuploidy with PA-PPA at 0.38 MOM, which means that it is less. She's got no other risk factors, and you're planning for assessing her for adverse placental outcomes, including preeclampsia, fetal growth restriction, planning her antenatal surveillance. Which of the following describes the risk category that is associated with? So as you know that the PA-PPA is less over here, and when it is less than 5th centile, you would be categorizing it under the current pregnancy that would be taken as a high risk factor. So earlier there was like minor, major we used to take, but now you take as low risk, moderate risk factors as well as high risk factors. Okay, we don't categorize as minor or major. You take it as a moderate or you take it as a high risk factor. And the last question for today would be a 29-year-old second gravida and previous live child at 12 weeks currently with no risk factors and comorbidities, and her BMI is 24. Normal blood pressure booking, no significant family history. But previously she had a SGA baby, live birth, and birth weight was 2.1 kilos at 39 weeks of gestation, delivered normally by spontaneous labor, and there is no other neonatal or maternal complications. She has no history of hypertensive disorders in previous pregnancy. What is the most appropriate management that you would be doing? So as you can know that, she has got no other risk factors like hypertensive disorders or nothing. So this all would be completely ruled out. Now you need to look into this table only. She had a previous small baby and that's a live child. So previous SGA, you will be taking it as moderate risk factors. And as you all know, when there is only moderate risk factors, there is no need to do uterine artery Doppler. You only have to do serial ultrasounds from 32 weeks onwards. That would be every 4 weekly. So that's going to be the frequency until she delivers. So obviously uterine artery Doppler you would be removing and performing serial SFH measurements with no need to have any kind of additional ultrasound. That's not fair because she already had a small baby, so you need to screen in this pregnancy. Routine anomaly scan and do ultrasound only if there is a clinical suspicion of small baby. No. Arranging for serial ultrasound scans, ultrasound scans from 32 weeks onwards and repeat every 4 weekly until she delivers. This is the most appropriate answer so far. Reassuring the mother that previous SGA alive baby is not a risk factor in this pregnancy, so only we wait and watch for the development of risk factors. That option is again definitely not valid. So that was about today's session. I hope it was useful. In case of any doubts or if you've got any queries, feel free to drop it in the comment box and we'll be happy to answer. Happy studying and wish you all the best and good luck for your exams.